I'm excited for today's guest and today's conversation on a personal level, as many of you being listeners of the podcast for a while know, I've had a lot of disc and spinal issues over the last 8 years that periodically flare up. I'm in a flare up right now. So I've really been interested in any sort of science that would give me really some answers into my problems, potential treatments, and things such as that. Today, I have with me Dr. Jeffrey Gross. Dr. Gross graduated from the University of California, Berkeley with a degree in biochemistry and molecule cell biology. That's a mouthful. He earned his Doctor of Medicine in 1992 from the George Washington University School of Medicine. He contributed to virology research during his studies, and after graduating, he undertook a residency in neurological surgery at the University of California, Irvine Medical Center until 1997. He then pursued a fellowship in spinal biomechanics at the University of New Mexico until 1999. We were talking off camera about his time here in Albuquerque. He is licensed in California and Nevada. Dr. Gross has spine practices in Orange County and Henderson, Nevada. He is a trained neurological surgeon. He specializes in athletic injuries and spine procedures and offers longevity and biohacking consultations. He is certified by the American Board of Neurological Surgery and is a member of several prestigious surgical societies. Since 2020, Top Doctor recognized Dr. Gross as a leading neurological surgeon, and he received Health Tap's 2022 Top Doctor Award as a top neurological surgeon in the United States. Dr. Gross founded Re-Celebrate, love that name, focusing on anti-aging and regenerative medicine. Boy, I'm getting tongue tied today. The mission for Re-Celebrate emphasizes offering modern biochemical treatments and considering surgery as a last resort, something that I've been contemplating and hope to avoid. Dr. Gross, welcome to the show.
Thank you very much. I'm pleased to be here and happy to meet a fellow New Mexican.
Yes, you know all about we were talking off camera about the green chili and all of the restaurants here, little buzzwords that you would have to live in Albuquerque or New Mexico to get. So it's a lot of fun connecting with Dr. Gross. How did your journey begin? How did you get into this type of therapy, longevity benefits, and stem cells in general?
Well, like most things, by accident, I suppose. I've been practicing spinal neurosurgery or spinal medicine now for over 25 years, and probably before 20 years into that practice, I noticed that not much had changed. The things I learned during my training from esteemed professors, including when I spent 2 years in your home state doing fellowship training, um, hadn't changed in probably even more decades. My professors learned to do things, they taught us to do them, and looking back, it was really the same kind of things for the spine. And patients would come to me, and there's a gap, and that gap is there are some first line treatments, time, anti-inflammatories, therapy, rehabilitation, core strengthening, a number of things, and even injections. And those things might help. They may help. They could help. They should help. But sometimes they just don't help enough or last long enough. And in those people, the last thing on the list is talk about surgery. Um, However, that's a big gap between non-surgical and surgical treatments. So there's a wide gap in there, and that gap, patients come in and say, "Yeah, I still have problems. I still have pain. I try to live with it," and you may be one of those. And however, I'm just not ready for surgery. Maybe mentally, it's a big deal, and I don't want metal hardware in my spine. I don't want a fusion surgery, and they're right to say that. And I have to give them all the options, and I say, okay, if you're not ready, we'll continue to help you along the way until maybe you become ready. But enough patients said to me, "Hey, what about lasers? What about this? What about stem cells?" And I heard that enough times, and put that together with things not really changing fast enough in the medical field here in this country, at least in my field, that I, instead of going to the annual, you know, spine doctor meetings where we say the same stuff over and over again, I started going to stem cell meetings. And as you mentioned at the outset, I do have a undergraduate background in those sciences, in molecular biology and biochemistry. So I had enough understanding to say, hey, this is an area I need to look into again. A lot had happened in the stem cell industry and field since the early research in the 80s after the Reeves accident, and which stemmed a lot of that. And there have been ups and downs, particularly in this country, and other countries have surpassed us. China, Europe, European countries have done a lot of work. They have long follow-up studies using stem cell type biology. So I finally went back and said, okay, uh, I I don't want to be the old dog who's stuck with the old tricks. I need to see what the newer tricks are. So I went back, I retrained, I retooled to add, ideally, this tool to my treatment of spine patients. But when you learn this technology, this biotechnology, it expands well beyond the spine. And I'm addressing other joints. And you learn how regenerative medicine reverses inflammatory damage, and it reverses deterioration and degeneration. And you apply that to all the cells in the body. And that's where you get into the longevity and the anti-aging and the biohacking side of things. So it's blossomed and I love it. I'm doing, a lot less surgery, which is great, right? We only, there's a role for it, but it's only for those who absolutely have to have it.
I love that. I really like that you touched on the gap between surgery and some of those other types of treatments, such as the spinal injections, which I've had several rounds of that over the years. I've had PT, um, the rest, obviously, things that bring down the inflammation. But then it seems like this big jump into surgery, which frankly really frightens me. I've known people at the gym where I work out to have surgery and not have very good outcomes. Now, granted, these individuals had other problems going in, but seeing what they went through, it scares me. It really does.
It should. It absolutely should. The fusion surgeries are large and involve, reconstructing your spine. It's a complete remodel. And unless you can't get out of bed every day for months on end and you have no quality of life, it really behooves you to look for all other options first.
So, how does stem cell therapy work, for the listeners to give them an idea of exactly what's going on here, what's the procedure, and how it works?
Well, I when I got into this field about 5.5 years ago to add it to what I normally do, which is it's modified my practice. Um, I looked for the best practices out there, and they don't necessarily come from the United States. So I follow the work of Philippe Hernigou from France, and despite 3 years of high school French, I'm sure I mispronounced his name. Sorry, professor. But so they have over 15-year follow-up in looking at stem cells for knees. And what they did is they took patients who were already scheduled to have a knee replacement. So they were already as bad as their knee could get. They were told they had osteoarthritis or they were bone on bone, and they had a lot of pain in the knee, and they were just looking for solutions. He said, wait, before you have this replacement, would you like to join our study? And I think they had about 100 people enroll, and half of them, they injected stem cells from that patient into the joint space. So this is analogous to what might be the disc space in the spine. They took the other half and injected the bone layer just adjacent to the meniscus of the knee. So in the spine, that would be analogous to the vertebral bony end plate, which is right up against the disc. And they found over time, over 15 years, they publish this every 5 years, I think, but at the 15-year mark, there was a very significant difference between the two groups. Initially, both groups did well and no longer needed a knee replacement. They had enough improvement in pain and function. And then at 5 years, the groups started to separate, and they continued to separate until 15 years. The bone injected group, over 80% of those patients were still doing well with their knee and still didn't need a knee replacement that was offered to them 15 years earlier. But the joint injected group, patients started to have problems again, and it was only 20 some patients of those remained in good shape. So the moral of this story is that the activity of the regenerative medicine, like stem cells, is best delivered in a structural setting, like a joint, to the bone just adjacent to the joint, because the meniscus or the disc is really doesn't have a lot of activity, doesn't have a lot of cells. It's sort of biological rubber. If you would, when you grow hair, the hair isn't the cell; it's a protein appendage of the cell. Like your nail are protein appendages of certain skin cells. Well, the cartilage in our body, of the disc, of the meniscus, elsewhere, is produced by cells, and those cells come from the edge of the bone. So we learn this here, but still, so many regenerative medicine doctors here in the States and elsewhere don't have the capability to move forward into this kind of best practice, and they're still injecting the joint. And they still get some good results because there's probably some reverse movement of the tissues of the implant. However, the activity that is stimulated for regenerative capacity, for healing, for youthful healing and restoration, is in your own stem cells at that edge of the bone where the growth plate used to be, right? That's a bank of stem cells that produce that joint or that disc in the first place. So we're tapping back into those technologies by how you deliver it, what you deliver, where you deliver. So we do injections in the bony end plate of regenerative biologics, which maybe we can get into down into this interview. But the stem cells is one aspect. There are other options.
So you're taking the person's own stem cells and using that for regeneration. Is that correct?
One can, and that was the study that was done in France. But there
Mm-hmm.
are newer offerings and options that when we talk about best practices, if we to do that now, I'm no longer using a patient's own cells. When Carol, you take your car to get the oil changed, you certainly don't want the old oil put back in there. And our bodies have been exposed to years of pesticides in the water, poor foods available to us, unless you're just the best super clean eater out there. If you've been eating, the breakfast cereal myth your entire life and eating all the sugar and all the pro-inflammatories, we don't have, the best supplementation in the world, right? Our food source is leached and not as organic and wild and free range and all that. So we also are exposed to electromagnetic waves and other pro-inflammatory / pro-degenerative forces and stresses. And our cells are busy fighting that through a process called chronic inflammation. And that increases pain, it increases disease states, it accelerates aging. We can go on and on. You've had other guests on who have talked about this at length. And the whole point here is I don't want to put someone's stem cells who have been exposed to all that back in the body. That can help. I mean, they're great, papers on the benefits, but why not get the best source, brand new oil? So we get that from mothers who donate after they have a C-section birth. They donate their amniotic fluid, their umbilical cord, their placenta, which was chock full of stem cells and stem cell signaling factors, which are even the more modern regenerative biologic we like to use. So these are readily available through FDA certified and compliant labs here in the US, and ethically donated and screened and tested. So it's ideal.
I'm glad you verified that because I was wondering the same thing. I wasn't wanting my own 62-year-old stem cells. I thought, that might not be the best outcome there. You're right about everything that we're exposed to and how the cells are, constantly having to regenerate. So that was very interesting. Now, I'm assuming, and I may be assuming wrong, that there may be a point of no return, or is time of the essence for somebody to seek this type of treatment?
Well, not necessarily. We're learning more about this. This is sort of the area under the curve problem, right? When we look at someone, let's say you have a knee degeneration, someone comes to us, we do a very specific MRI and we look at the deterioration, uh, how it looks, the physical deterioration, but we also study the patient's chemistry. We do blood tests, we look at inflammatory markers, and really the amount of inflammation and deterioration matched clinically with how much pain and problems that person has gives us a sense. So if you haven't had a lot of sports injuries and your knee is just starting to give you trouble, you probably don't have a lot of wear and tear or osteoarthritis, and we're going to have earlier, easier to get benefits. Whereas if you've had multiple meniscus surgeries to clean up the meniscus tear, maybe, and you have a lot of pain and you've sort of ignored it, and you don't eat well, and you smoke, and you've got all kinds of other health issues, we're going to have a lot more of a challenge to treat that knee. So every little thing you do towards an anti-inflammatory lifestyle, diet, supplementation, sleep, breathing, exercise, movement, muscle mass, we can go on and on, has a role in this, because the disease of osteoarthritis, of degeneration, is a inflammatory bone problem.
Mm. Do you see, okay, inflammation plays into this. Genetics, do genetics have a role with this? And then, of course, certain things we can do at the gym. There's obviously, I did bodybuilding shows for 10 years. So you're always pushing things to the
Right.
limit. And I'm sure in my early days, I did some things that weren't the best practices.
Well, we all did, I'm sure, but yeah, I mean, you know, we we like mechanical activity of the joint within decent parameters, not overdoing it. When we do these injection procedures, we don't have downtime. We want people up and stimulating what's called the mechanoreceptors, the little sensory endings in the joint and in the bone that release the cell signaling for bone remodeling and building. And remember, muscle mass and bone density are stimulated and improved by exercise activity, and those activities and those masses are correlated with longevity. So the more muscle mass, the more bone density, the longer you live.
Mm.
And that's why when you go to a nursing home, you see elderly, frail people. They have low bone density and low muscle mass. So there's a lot of work in that area, and the statistics are quite clear. So activity, weight bearing activity, stimulates the joint, stimulates your own stem cell populations, even without any of these treatments, are helpful in the long run. So even though you might have overdone it in a joint, or here you have back pain or something, those can be addressed because they can slow you up from doing the exercises you want to do and need to do for longevity.
Yes, that's kind of where I'm at right now, where I'm still at the gym, I'm still lifting, but there's a lot of exercises for my lower body that are off the table because of that compression. So, for instance,
Right.
heavy leg press, not so
Yep.
good for me. Any kind of barbell on my back, not the best option. Deadlifts,
Right.
things such as that. I've really had to rework my routine and do a lot of single leg stuff. But I'm in
Yep.
total agreement that strength training to me is a non-negotiable, and it's almost would be irresponsible at this point not to do it, knowing what I know and seeing what I see working with clients in the industry, in the fitness industry.
I'd
I
agree with you completely.
definitely agree.
Yeah.
Now, I was diagnosed with rheumatoid arthritis, so a inflammatory disease, autoimmune disease, the same year that I had my first back problem, the same year I had my first back injury, which was at the L3, L4, and then I went on to rupture at the L4, L5. And initially I was told, oh, the rheumatoid disease doesn't really have an impact. Now I'm hearing differently. What are your thoughts on that? Can autoimmune adversely affect the spine?
It can, because autoimmune is a hyper-inflammatory state, and rheumatoid arthritis is one of those states, which can have a genetic uh, component. And you asked me earlier, I think I failed to answer. Do genetics have a role? They do, but we're learning they have less and less of a role, and really, it's more about epigenetic, meaning what we do, our lifestyle, our activities, our behaviors, that tell which of our genes, uh, to be called upon. So your genes are pretty set, but how you access that information, how often you access it, is epigenetics. So genetics probably have a less and less lesser role than we always thought. However, yes, if you have inflammation, whether it's from a thyroid problem, rheumatoid arthritis, have had long COVID or Lyme's disease, or something that has increased or set off your inflammatory system out of balance, it can accelerate the degeneration of a joint that might already be mechanically stressed. So it could have thrown you over the edge. It could have been the straw that broke the camel's back, or your back in this case. And we see that because we have people with inflammatory joint pain and we give them probiotics supplements, which are known to work to suppress inflammation. And we see some improvement in the joints. So we know that the joints are responsive to systemic levels of inflammation. And that's why we like to look at those blood markers in inflammation, which aren't part of normal blood tests that a routine physical might get, depending on your physician or how your health is managed. So I agree with you. I think diet and exercise and all these things matter, even when you have an inflammatory issue.
Mm. Now, and you kind of touched on this before, but is there anyone who's not a good candidate for stem cell therapy where you say, this just can't help you?
Well, if you're on a blood thinner that can't be stopped for a short while, usually because of a risk of heart attack or stroke or clotting, we can't do the procedure because it involves a needle into the bone marrow. So that won't work. If you have cancer, we don't know what stem cells will do for cancer completely yet. There's some evidence that it may be good, there's some evidence that it may be bad. So we're not using stem cells for people who have active cancer disease at this time. There are a lot of things being researched in the stem cell industry separate for cancer problems, like what are called CAR T cells and other activated immune cells. Those are getting a lot of attention, but they're separate from this rather generic application of stem cell or stem cell derived signals, which are smaller particles.
Mm, that's interesting. Now, with this procedure, and we're beginning to see it take hold in the United States, as you said, but we're lagging behind somewhat. Where are we at? Because I know of somebody who's actually flying to Cabo to get this therapy, and I was wondering why. Where are we at in all this?
It's a great question. So, there are many clinics in Mexico, Central America, and other continents that you can go, and those places have active stem cell programs. Um, they are allowed to advertise, so you have a lot of advertisement on the internet and things like that. Here in the United States, the FDA claimed jurisdiction on your cells and your biologics.
Mm,
So it is we have to be very careful. We don't want to make any claims that have not yet been given the gold star by the FDA. So there's a great myth around that, and until there are a lot of political and economic pressures, so we have to,
Mhm.
that affect that. So we can't make any claims that we can cure or treat any disease or condition until the FDA says, based on what they determine is adequate information for us to do that. That doesn't mean those treatments currently are unapproved or disapproved. They're just not yet approved for that speech, for that claim, for that wording. So we can't advertise much on the internet. We cannot have advertisements on Google or Facebook because they're right in the pocket there of not wanting to run afoul of those pressures. So there's a lot of uh, influence in that. So therefore, in the United States, you don't hear as much about it. It's harder to find. But we're, physicians like me are across the country. We have annual conferences and meetings, and we try to publish. It's just difficult.
So, what is it going to take, do you think, to bring this into approval and bring us up to speed?
Well, I think we're up to speed. Um, the FDA doesn't tell
Hmm.
you, a patient, what you can and cannot do or should not do. It doesn't tell us as doctors what we can and cannot do for the best interests of our patients, including giving them more options than they had before. If there are, if you are okay with not drinking the Kool-Aid, you want to do what's best for yourself, you should seek all options and get those opinions.
Hmm.
But what it will take to be mainstreamed and okay for the Kool-Aid drinkers would be to have, what'll happen is big pharma will take a larger and larger interest, monetize it, and then when those power brokers have a larger involvement, it'll happen.
I see. Well, I want to shift gears just a little bit. I was thinking earlier as we were speaking about the differences that people, like you had mentioned, okay, somebody might need surgery if they're stuck in bed every day, they have no quality of life. And that's happened to me for a period of time, but I've always been able to heal somewhat and get back into the gym. But what causes these differences? Because a lot of time the MRI for one person might show extensive spinal degeneration and damage, but yet they're not having pain.
Right.
That one has always perplexed me. And then somebody's MRI isn't quite as bad, so to speak, as that other individual, but they're in tremendous pain. What is the
Right.
reason for this?
Well, that is your observation is one that we in the medical field have as well. We're not supposed to treat MRIs. We're not supposed to treat X-rays. We treat patients. So if you have someone who's not suffering, even though their spine looks really degenerated, then we just give them some advice and prevention and strengthening exercises, and keep an eye on them. The alternative, though, is when you have someone, like you said, who's miserable and they have, not so bad degeneration. We need to investigate those people more precisely. That's called precision medicine. Why do they have pain? Where exactly is it coming from? Can we turn it off temporarily with a blocking injection? Because that helps confirm maybe where it's coming from. If it's all over, it might be something else. It might, could it be too much inflammation? Are there ways to settle that down? It just requires work, a lot of visits, dialogue, asking lots of questions, being examined in a detailed, dutiful way. And I know there's a lot of watered down, medicine these days because of, what's going on in managed care and mismanaged care and, economically driven care, where a PA may come in the room, or not even your doctor, and say, here are your MRI results, and not even really spend a lot of time examining you. So that's not adequate.
I would agree. Where do you think we're going in the future with all of this? What's on the horizon?
So we're working on a project here for helping people with disc degeneration. You may have heard this phrase. I don't love this phrase, but it's called degenerative disc disease.
Mm-hmm.
It's not a good phrase because it's not a disease. You can't catch it. I can't inject it into your vein and give it to you necessarily. It's a garbage term for doctors who don't want to sit and explain what's going on, to just simplify and pat you on the back and send you on your way. Oh, you have DDD, you know. And the same thing with joints, degenerative joint disease. It's not a disease per se. Yes, rheumatoid arthritis and some other things can be a diffuse disease of degeneration, but it's really a disease of inflammation. Um, anyway, I'll get off my soapbox for a moment and say where we're going with this is to reverse it and restore it. And that comes from understanding the biology, understanding how that disc or that joint was made in the first place when you were in utero, and tapping back into your own bank of stem cells and healing potential, re-stimulating that to help that joint remodel and improve itself and make more collagen proteins and improve the height of the cartilage. Now, discs are tricky because they're made of a couple different type of embryonic tissues. So the stem cells support the articular aspect, but we really need to enhance what's called the nucleus of the disc, and that's coming with some cushioned enhancement injectables, and it's coming. We're working on it. It'll be, coming online slowly because it's being suppressed by, companies that make screws and rods, right? That's a multi-billion
Mm-hmm.
dollar industry. There was a company 10, 12 years ago called Disc Cure, I believe, and they are and they had a device that would inject like a rubber ball material into the center of the disc. Well, that great idea got bought up by a much larger company that makes screws and rods, and they shuttled it. It's gone. It was this a promising technique. So
Wow.
just like you hear about the carburetor that gets 100 miles to the gallon, and the oil companies bought that up and got rid of it. So same thing here.
Wow. Wow, I'm learning so much about this whole process and what's been holding it back. And I got that diagnosis as well, the degenerative disc disease. And I was questioning the disease portion of that, thinking, okay, yeah, my discs are degenerating, but no, it's not
It's not
necessarily
a
caused,
disease.
not a disease. So I'm
Yeah.
glad you clarified that. Now you're talking about being able to regenerate these discs. What if it's ruptured? What can you do in that case?
Yeah. So if the rupture itself, a part of the disc is out of its normal housing, I don't have a regenerative medicine solution for that. And that might require a small surgery to clean that up. We call that a microdiscectomy. It can be done through a very tiny incision, but it's okay because you do that incision, you clean it up, and you can do the stem cell and regenerative type activities at the same time while you're there. So that's not a big deal compared to a fusion surgery of the spine, which involves screws and rods and plates and different type of metallic tinker toys that we've been putting in for many years.
Yeah, my issue is that L3, L4, that is the contents are sitting on top of the nerve root controlling the left side. So I get that pain, that numbness, that
Yep.
burning down the front of my leg.
Right.
At its worst, it has kept me from walking. Right now, it's just, I just deal with it. It's just, I just deal with it. I take note of what aggravates it. I have a lot of exercises I do, but
Right.
very frustrating because it's been an 8-year journey. So this has been really interesting to learn these things.
Yes. So may or may not benefit from a small cleanup. There are other older techniques that you might have an injection to help dissolve some of the herniated disc, or the what you call the ruptured disc.
Hmm.
Rupture refers more to the tear, but the meat of the disc that comes out of place, it's called a displaced disc or a herniated disc. You see those words.
Yes, yes, I saw those on my MRI. Now, why do you think? Because I feel like stem cells, there's been this debate going on, oh, forever since I very first heard about stem cells and stem cell therapy. And you had mentioned back Christopher Reeve, when we first started to take note of these things. What, why are people so skeptical? What's going on there?
Propaganda mostly. There are myths about, you're harvesting babies to get these, and they're um, oh, I heard it's illegal, stuff like that, and those just aren't the case. And but big pharma certainly wants people to believe that stuff.
Yes, I would agree. And I've been hearing those things forever. And I remember hearing, oh, this is done in an unethical way, what you said about the babies and being just horrified. And now knowing what I know, no, that's not how it is. How would you address someone who is skeptical? Maybe they're interested in this, but they're skeptical about it.
Yeah, do your homework and ask questions. Don't just rely on what you see on the internet. It's may not be accurate. So, speak to a physician who practices in this field. I'm not the only one, and ask the questions. Where do you get the materials? How are they tested? What are the results? Do you have some case studies? What scientific articles or journal articles do you rely on when you're applying this technique? Because we're nothing. There's nothing I'm doing that's shooting from the hip. I'm standing on the shoulders of giants who have done a lot of good work in this area, clinically, in the basic science in the lab. I vet the products that we use that are supplied. They're tested and screened each dose, so we keep a record of it. And I use it. I've used it myself on myself and on family. So I feel safe and I feel good about it.
Where do you think, and we kind of touched on this earlier, but stem cells, where do you think it's branching off to? We've talked about, how it can help with the regeneration of discs and how it can help with, say, your knees and problems such as that in the joints. But beyond that, where do you think we're going with all of this?
Well, I think you're seeing a couple different things. You're seeing some specific use of stem cells to address cancer, and Big Pharma already has some projects in that. So I think that'll come. In fact, there's already an approval, I think, for one or two different applications. Um, and that's really using certain stem cells or certain cells modified by the immune system and things like that. Uh, I think we are going to see, we didn't really talk about exosomes, and if you allow me just 1 minute on that,
Oh,
you know, I,
absolutely.
I refer to stem cell and smaller signaling particles. Well, we all use this phrase stem cell here, and as part of this whole regenerative biology, those stem cells and all cells for that matter give off very small cell to cell communication packets. Have a little bit of a membrane like a cell. It's got some growth factors and microRNAs, and those are given off, thousands of them to go to other cells, so that cells in a group, in a tissue, in an organ can all kind of behave similarly. They can all either be inflamed together or they can regenerate together. So that cell to cell signaling is what we rely upon in some of the joint work that I do. We can now just obtain those signaling particles, and we like those because if you have stem cells delivered, they don't last but 1 to 2 weeks, but the benefits go on for perhaps months or longer. And and why is that? Is because the stem cells you got delivered these particles. These particles last longer. They travel better in tissue. They cross into the brain if you want or need that through the blood-brain barrier. They are easier to handle and store, and they're less expensive than stem cells. They come from the same amniotic fluid and umbilical cord sources and labs. So these are called exosomes or nanoparticles, and I like these. So where are we now? Now that I've inserted that, where are
Hmm.
we going with that? Is we're going to probably have designer exosomes, exosomes
Wow.
that donate mitochondria to help improve muscle mass or convert white fat to brown fat for weight loss. We're going to have exosomes that stimulate the immune system or help remove cancer cells, even as a preventative in someone who's at risk, perhaps because of a genetic problem, and exosomes that are found to stimulate the pancreas to slow the inflammation of the islet cells to improve insulin sensitivity. I mean, this goes on and on. And there's work in this. This is published. Most of this comes out of China, where they're way ahead, and other Asian countries where they're way ahead in this area.
Wow, this is the first I'd heard of the exosomes. That's really fascinating. Yeah, I'm assuming as you were talking and you were talking about this whole process, somebody would benefit more, as you said, if they didn't have, like, they weren't a smoker, they're not insulin resistant, they're insulin sensitive. How would someone prepare? They want to do this procedure. What should they be doing? Should they be doing some type of preparation with their lifestyle habits, their nutrition, their exercise in advance of this if they can?
Totally, they should. I don't want to offer someone a regenerative procedure if we're going to put it into an environment that's not receptive to it. It's not going to have the result. I want to help you benefit from the procedure as a patient. So yes, you should, look at your diet and your exercise that you can do. A lot of people with joint problems can't do a lot of exercise. So diet, exercise, mindfulness, sleep, breathing, hydration, supplements, uh, every little aspect to help slow the inflammatory proteins and processes in your body.
It's all the things I do with my health coaching clients, all of those habits.
Exactly.
I'm curious,
Exactly.
what supplements do you think are worth it, so to speak?
Well, I when I first meet with people and we talk supplements, I I don't like to overwhelm them. So I start with what I think are the five most anti-inflammatory supplements starter pack, and I recommend everyone be on vitamin D, 5,000 IU's. Uh, there's this myth that I'll just go out in the sun and get some vitamin D. You don't get vitamin D from the sun. You convert vitamin D2 to vitamin D3 in the sun, but how much vitamin D2 do you have in your system? We don't know. So take your 5,000 IU's of vitamin D3 daily. Uh, that that supplementation is associated with a reduction in all causes of death. Boom, just made you
Wow.
live longer there. Second, I recommend probiotics. This is this is something that we have this interaction with the earth and in the soil, and there are bacteria, and those bacteria live in our gut, whether you want them or not. And the diversity of that bacteria helps us process certain phytonutrients that we can't make on our own, and they make small peptides in our body that signal the brain and help cognition and signal other things. So they help suppress inflammation. So I'm a big fan of probiotics. I like to mix up the brands, so I'm always getting diversity, and I take it daily. Number three, fish oil. Fish oil is significantly underestimated. Most people who take one fish oil a day are still underestimating. Most of us should have about 3,000 milligrams of high quality um, fish oil, omega 3, EHAs, and DHAs a day. So I usually take one with each meal if I'm having three meals. If I do more of an intermittent fasting, so I have to condense them down, but I try to get 3,000 a day. Your omega 3 index, which is a lab test, can measure those. And even people I have that take three a day are low. So you may need more. And it's okay. And people say, "Oh, I have fish a couple times a week." It's not enough. You still need this, and just get a good quality fish oil replacement. So that's three. The fourth and fifth one are my bedtime medicines, my supplements, magnesium and melatonin. All of our cells need magnesium, and especially during night, during the repair phase, during the circadian rhythm, dark
Mhm.
cells rid themselves of some inflammation during the night. So you need your magnesium. There's controversy as to the different forms that it comes in. And I'm not sure the answer, so I take a multiform. It has different forms of magnesium. And also at night, melatonin. Melatonin is a hormone made by the pineal gland in the brain. That gland kind of dries up like a raisin after puberty and doesn't produce well. But that pineal gland, not melatonin not only helps you sleep, but if you sleep fine, it does support your cells. It's a hormone, supports those cells doing their repair during the dark phase. The dark phase being night. We need to respect that circadian rhythm. So I'm a big fan of melatonin at night for cell repair, if not for sleep. And I sleep well, but when I take melatonin, I sleep and dream more. I sleep deeper, and I track my sleep. For those of you out there that have wearable tech or a cell phone app, yeah, there you go.
My
You
Aura
Aura Ring,
Ring.
yeah. So those are great ways to track your sleep quality, and so I take 10 milligrams. That's a good dose of melatonin every night.
I would agree with all of those are in my stack. I kind of go in and out of the probiotics and try different kinds and whatnot, but I am a
Mm-hmm.
huge fan of the melatonin and have been taking a quality melatonin for quite some time. I feel sleep is one of those things that's underrated. It's so powerful. And I often, in fact, I changed my health coaching program recently where we introduce that component of sleep earlier because without it, there isn't weight loss. There isn't the body composition
Right.
goals aren't reached, especially in women over the age of 50. It is so critical in so many different ways.
And I should mention this for optimization before a regenerative procedure, and in working towards fighting inflammation. Hormone optimization, both in men and women, is an important element, and a lot of doctors won't do it. So you got to make sure you push and find the person that can do it for you.
Agreed. Agreed. I went on bioidentical hormone replacement therapy. Oh, at age 50, I'm 62 now. I have no intention of going off. She's got everything optimized. And at the time that I went, there was still a lot of that fear mongering around
Yeah,
the Women's Health Initiative, and I was scared to death to take hormones. But
and millions were, and millions still are, and some doctors haven't even recalibrated to that, the problems with that, those studies. So good for you.
yeah, it's very important. Well, Dr. Gross, this has been fascinating. I've learned so much. And as we start to wrap up, a couple of questions. How can listeners get a hold of you, perhaps work with you? And was there anything we didn't cover today that you think would be beneficial for people to know?
Well, we covered a lot. I'm sure we could continue. We could do a second session anytime, but I think we covered it enough. I think it's important to say that all this is for educational purposes. I wasn't meant to treat any individual, and I'm not making any claims. I don't want the FDA to come and bury me in the desert here in Nevada. But I'm based in Las Vegas, and our business is called Recelebrate, because we're celebrating the renewal of your cells. So RECELLEBRATE, and we're on that. Use that word. You'll find a website, Instagram, Facebook, LinkedIn. It's same word everywhere.
Great. I will put all of that in the show notes so
Thank
people
you.
can learn more about what you do. And again, thank you so much, Dr. Gross. I appreciate
Thank
you
you.
taking time to be on the show. I know you're very busy.
It's my pleasure.
And to our listeners, wherever you are in the world, we wish you every blessing. Bye for now.